All right, let's get right into it. I want you to imagine a medical emergency that doesn't start with a big bang, but more like a whisper. Just a strange collection of symptoms that on their own don't seem to connect. But when you put them together, they point to this life or death puzzle that doctors have to solve like yesterday. And it's all happening deep inside the bloodstream. Today, we're unraveling that very puzzle, thrombotic thrombocytopenic purpura, or TTP.
So think about it. How in the world do you connect the dots between someone who is suddenly confused, is covered in these tiny little bruises, and is just overwhelmingly tired? Well, that's the central mystery of TTP. It's a condition where the problem isn't one big dramatic clot, but thousands, maybe millions of microscopic ones, causing absolute chaos all throughout the body.
So to make this real, let's look at a classic case. A 32-year-old woman shows up at the hospital. She's confused, she has these telltale pinpoint bruises called petechia, and her blood work is it's terrifying. Her platelets, the little things that help your blood clot, they're down to 18,000. They're practically gone. Her hemoglobin is so low she's severely anemic. And then, here's the kicker, her standard clotting tests, perfectly normal. And these are the first crucial clues in the mystery.
Okay, so to understand what's happening, we need to zoom in. I mean, way in. We're going microscopic, right down to the crime scene itself, the tiny blood vessels. And what we find isn't a single event, it is widespread, systemic chaos.
You know, what's amazing is that our bodies have a built-in system to prevent this exact kind of chaos. Normally, the lining of your blood vessels releases this stuff called von Willebrand factor, or VWF. For our purposes, just think of it as super long, super sticky tape. Now, to keep everything from getting gummed up, a special enzyme called ADAMTS13 comes along. It's like a pair of molecular scissors, and its only job is to snip that sticky tape into smaller, manageable pieces so blood can flow right on by.
And this slide just lays it out perfectly. On the left, you see the normal system. The molecular scissors are working, the sticky tape gets cut, everything flows beautifully. But in TTP, on the right, those scissors are missing in action. The sticky tape stays long, and platelets just start glomming onto it, creating this massive microscopic traffic jam all over the body. The platelets get used up, which is why the count drops, and red blood cells, well, they get shredded to pieces trying to squeeze past the wreckage.
And that shredding of red blood cells, it's got a name, microangiopathic hemolytic anemia, or MAHA. This isn't some chemical problem. We're talking about straight-up mechanical destruction. The cells are physically torn apart by the sheer force of navigating these tiny clots. Under a microscope, you can actually see the fragments. They're called schistocytes. This is exactly what causes that severe anemia we saw in our patient.
So we've seen the crime scene, we've seen the damage. Now let's zero in on the culprit. This entire catastrophe, all this chaos, it all hinges on one single missing element: those molecular scissors.
And here it is. This is the smoking gun. The definitive test for TTP is measuring the activity of that ADAMTS13 enzyme. And in patients with TTP, its activity isn't just low, it is severely deficient. We're talking less than 10% of normal. This near-total absence is what seals the deal and confirms the diagnosis.
So why do the scissors go missing? Well, it really boils down to two scenarios. In over 90% of cases, it's something called acquired TTP. This is where the body's own immune system gets confused and creates these rogue antibodies that just attack and destroy the ADAMTS13 enzyme. Then, much more rarely, you have congenital TTP, which means a person is born with a genetic mutation and their body simply can't make the enzyme correctly in the first place.
Okay, so here's the clinical dilemma. How do doctors solve this puzzle in time? They can't just sit around and wait for that ADAMTS13 test to come back. That can take days. And patients with TTP don't have days. So they have to start the investigation immediately, making a diagnosis based on the clues right in front of them. And they have to move fast.
To help them do this, clinicians have a really clever tool called the plasmic score. You can think of it like a detective's checklist. It systematically looks at all the lab results, things like a super low platelet count, signs of that red blood cell destruction we talked about, but it also considers other factors that help rule out different diseases. A high score, like 6 or more, basically screams this is very likely TTP, and it gives doctors the confidence they need to start life-saving treatment right away.
Now, here's one of the most important clues of all, and it's a bit counterintuitive. Remember our patient's totally normal clotting tests? That's a huge piece of the puzzle.
In a lot of other big clotting disasters, those tests would be way off. The fact that they're normal in TTP is what helps doctors separate it from other conditions that can look similar. Sometimes, the most important clue is what's not there.
So, once that suspicion is high, the race against time is on. This isn't just a treatment plan, it's a full-blown rescue mission to stop the microscopic damage, restore balance to the blood, and save the patient's life.
And if you ever needed a visual for why this is so urgent, this chart is it. Without treatment, TTP is almost universally fatal. We're talking a mortality rate of around 90%. But with modern, aggressive treatment, that statistic does a complete 180, with survival rates soaring to over 85%. It is honestly one of the most dramatic turnarounds in all of modern medicine.
The cornerstone of this entire rescue mission is a procedure called plasma exchange, or PLEX, and it is an incredibly clever two-pronged attack. The machine takes out the patient's plasma, which gets rid of all the bad stuff, both the rogue antibodies attacking the enzyme and that excess sticky VWF. Then it replaces it with fresh donor plasma, which is full of the healthy functional ADMTS13 enzyme that the patient is so desperately missing. It takes out the bad and puts in the good, all at once.
Now, Plex doesn't work alone. There's a whole supporting arsenal of therapies. Doctors use steroids to calm down the overactive immune system so it stops making those destructive antibodies. There's also a newer drug, caplacizumab, which is incredible. It acts like a shield, directly blocking platelets from sticking to the VWF, which very rapidly stops new clots from forming. And for really tough cases, they can use rituximab to wipe out the specific cells that produce the antibodies in the first place.
Okay, now this is a critical takeaway. It might seem totally intuitive, right? A patient's platelet count is dangerously low, so just give them more platelets. But in TTP, that is a huge mistake. Transfusing platelets is literally like adding fuel to a raging fire. You're just giving the disease more raw material to make more of those dangerous microscopic clots. It's only ever considered in the absolute most dire, life-threatening bleeding emergencies.
Surviving that initial TTP attack is a massive victory, no question. But the story doesn't just end when the patient leaves the hospital. We really need to talk about the aftermath and what life looks like for a survivor.
A major concern for survivors is relapse. As you can see here, the risk is pretty significant. Some studies show it can be as high as 30 to 50%. Because of this, patients need to be monitored for the long term. Doctors will regularly check their ADMTS13 levels because a drop in that enzyme's activity can be the first warning sign the disease might be getting ready to flare up all over again.
And that brings us to the final crucial takeaway. This quote is a powerful clinical pearl that every doctor learns. If you see a patient with a low platelet count, evidence that their red blood cells are being destroyed, and they have normal clotting studies, you have to think TTP until you can prove it's something else. It's a simple formula that sums up this entire complex puzzle and, most importantly, saves lives. It's a wild reminder that sometimes in medicine, the biggest clue isn't what's wrong, but what's unexpectedly right. A devastating clotting disorder where the standard clotting tests are completely normal. That is the paradox at the very heart of this microscopic mystery.